With me today is Dr. Marc Glickstein. He's a radiologist, a senior attending radiologist with an active clinical practice in neuroradiology and general radiology in Connecticut and Massachusetts. He's on the senior radiology staff at 7 area hospitals in those 2 states. And he's also the founder of MedEvents. It's a medical demonstrative evidence consulting firm where he works to put together the kind of demonstrative evidence that you're going to see in today's presentation. I am Morris Singer. I'm a practicing lawyer and the founding attorney at the Boston Expert Witness Group, as I said before. Just in terms of the format for today, Dr. Glickstein is going to present a number of examples of the demonstrative evidence that he's created to help illuminate radiological and medical issues in the cases that he's worked as a consultant on. And afterward, I'm just going to speak for a few minutes about the admissibility of this kind of evidence, particularly with regards to Massachusetts law. So I apologize to out-of-state listeners. I'll try to touch on that a little bit as well. And then at the end, we'll have Q&A. And of course, as some of you have already picked up on, there is a chat feature in the webinar which will allow you to ask a question at any time. And if we see a question, we'll try to incorporate that into our talk as we go. So with that, I'm going to turn it over to Dr. Glickstein. And he will present from his slides. Just a moment.
Okay. Hello, everybody. Can you see my slides?
Yep.
On the, you can see. Okay, good.
I can see it.
Good. So thank you for taking the time out of your busy schedules to be here. And I'd like to share with you some of my own experience with demonstrative evidence and how it can help you and your practice. Well, we all know certain physicians that are popularized in the media, and these are usually the typical general practitioner types or emergency room or whatever. The physicians that we don't know are the radiologists who are behind the scenes, and most people don't often have a chance to interact with them. And just as radiologists are behind the scenes, so are the actual images and the tests that people undergo. So just to introduce things a little bit, because a lot of this is really about a way of seeing and a way of presenting. So when I show this picture, usually in any group, about 50% of the people will look at this and see one thing, and 50% will see another. So there's actually 2 images here. One is an old woman, and here's her nose, here's her mouth, and her pointed chin, her hair. And other people will, instead of that, see a young, beautiful girl here. That's her profile, that's her nose, that's her chin, that's her ear, and she's wearing this beautiful hat. So similarly, with this image, some people see the saxophone player outlined here. Here's the head, the nose, the mouth. Here's the saxophone. And some people instead see the face of a young woman with the 2 eyes, her nose, and her mouth depicted there. So that's just by way of saying that it's all a matter of how you look at things. So my own case, my background is that I am a practicing radiologist. I've been involved in medical legal consulting. I've served as an expert witness, and I also have a history as a photographer. So I've got a good handle on imaging and imagery and how to convey that. Well, radiology itself is very arcane. It's abstract, it's unfamiliar. It's at the same time, it's very graphic, it's concrete, physical, and visual. And because of these qualities, it lends itself to a graphic presentation. Well, demonstrative evidence in radiology has been affected by the digital world. There are a whole variety of factors, and we won't go into all of these, but there are a whole variety of factors that go into how images are created, how you can manipulate them, things that affect them, things that make them more or less intelligible. Well, witnesses are confronted with the difficult task of, and that is expert witnesses are confronted with the difficult task of clarifying complex medical information to a jury of laymen. And jurors themselves are confronted, or arbitrators are confronted with the difficult task of understanding and retaining information with which they have no common experience. And we all know these visual truisms, seeing is believing, pictures worth 1,000 words, etc. But these things basically show that we do put a lot of stock in visual presentations. Demonstrative evidence can be a great help to the jury, and it can be a help for attorneys to try to display their cases. Visual aids empower the jury. It allows them to draw their own conclusions independently. Converting words to images makes them come alive. It improves comprehension, increases juror engagement, and it has been shown that multiple senses producing information allow the information to be retained in a more efficient manner. And the other important thing is that demonstrative evidence can leave with the jury into the deliberation room and can have an effect even after it's presented. Well, how the images, how radiology images or x-rays are perceived really depends on who's looking at them. Obviously, the radiologist, the non-radiologist, MD, or the layperson are all going to have different experiences to bear on how that image or how that information is processed. And by layperson, I mean not only the jury, but also the judge, the attorneys on both sides will also have a certain ability to retain and reflect on the information. So it's been shown that the most important factor in juror decision-making is the strength of the evidence, and I would submit that demonstrative evidence allows you to make a strong argument. Well, my task is to accurately present this information that is graphic and that is meaningful to a jury of lay people. Well, this is a slide that basically shows 4 separate images from an ultrasound examination, and if you're not a radiologist, and even if you are a radiologist, you can sometimes have a hard time seeing what is depicted on these images. So I can tell you, looking at this, and I think to a layperson, these things all look totally unintelligible. But here you have an image of the thyroid gland. Here you have an image of an upper abdomen showing the gallbladder over here with a gallstone within it. Here's an image of the liver with the top of the kidney right adjacent to it. And here's an image from a breast ultrasound where if you didn't have an annotation on it to know where that came from, you really would have no anatomic information on there to allow you to say what tissue part that was. So it's very difficult for people to understand these things, and using images such as this to display them and get up in a courtroom and try to show that to a jury and explain it to them is not going to have very much of an impact. People are not going to understand what you're talking about or what you're trying to show them. I mean, even if I show you this gallbladder over here and a gallstone, unless I really clarify that, it just doesn't make any sense. Well, here was an example of a case that I was involved with where that's exactly what was done. There were some complicated medical issues. The attorney in that case had gotten essentially reproductions of the ultrasound examination, had them blown up into large poster size prints, and this is what resulted. And I realized when showing this case and talking to him about that it didn't matter. I mean, this was really not effective demonstrative evidence. It was showing something, but again, nobody was really going to understand what they were looking at. As opposed to, for example, a case like this, which is a case that I was involved with, where by taking some common reference points, trying to synthesize things, trying to explain it in an intelligible way, I think people have a better idea of what was going on. In this particular case, this was a personal injury case where there was a young girl who fell off of a balance beam at a gymnastics facility. And the allegation in this case was that there were two opposing arguments in this case. One was that it was alleged that she wasn't spotted properly and that she struck the balance beam when she fell off it. And the other argument was that, well, she just simply fell off the balance beam and she fell on an outstretched hand and had a fracture. Well, in fact, in this particular case, this was a supracondylar fracture, which you can see right there. And this is a typical kind of injury for a fall on an outstretched hand. So I think that the x-rays in this case illustrated the mechanism of injury and were able to convey it in a comprehensive manner. And I basically just correlated that with an artist's rendition and normal x-rays for comparison. Well, here's an example that was taken out of a, I think it was an ABA, American Bar Association journal, for an advertisement for demonstrative evidence from a company that provides this. And I put this in here because I think it illustrates something, which is that the radiologist as a professional can display things and explain them in a much better way and than a simple technician who's basically just trying to reproduce something that's provided to them. And the problem with this particular case is that there was an issue of a vertebral body fracture here at L2, which they correctly identified and displayed, but the labeling is wrong here. So they labeled this as the spinal cord, where in fact the spinal cord doesn't actually extend down to the L2 level. It terminates much higher up at the T12 level, and you really got the nerve roots coming down here. So I think what that illustrates to me, and I hope to you, is that the input from a medical professional can better explain the findings on these types of images. Now, demonstrative evidence can be used in personal injury cases, it can be used in medical malpractice cases. This was a personal injury case where there was an allegation of somebody who had a motor vehicle accident and was alleged to have disc herniations. But in fact, what we had in this case was a pre-accident view showing the L4-5 vertebral body. The subsequent studies were read as having disc herniations, but in fact, I would have termed this more of an annular bulge rather than a disc herniation. But nonetheless, we can see on the pre-accident view here that we have this finding here. We have a schematic view over here to illustrate the disc and exactly where this so-called annular defect or annular tear is. We can see a post-accident view here, basically showing exactly the same thing as was present on the pre-accident view. And we also have several subsequent follow-up studies that all show essentially the same thing. So this shows, demonstrates stability, and it also shows that whatever was present here after the accident was clearly present prior to it as well. Sometimes, depending on the way that images are created, we can create actual movies out of this, and I've done this in several cases. Here's an example of a patient who had trauma and had a mandibular fracture, and hopefully this is going to show for you. This is a 3D video animation of the CT scan. Whoops, I'm sorry. So basically what I've done, what I have on there is it's a voice overlay that I've actually incorporated into the video, so that in a case like this, if somebody wanted, I wouldn't even have to be there to narrate that, and the voice would be present. This is a 3D video animation of the CT scan on Susan Markel. The fracture of the left mandible is outlined in the red dots as depicted on the screen. As we rotate the CT scan, from side to side. You can see the separation of the fracture fragment. Okay, I'm not going to play through the whole thing just in the interest of time, but you get the idea with that. So we can do that with frequently in CT scans or MRIs, depending on how they're acquired. Here was another example of an MR angiogram of the hand, where basically we're depicting the blood vessels in the hand, and it was a fairly complicated case where there was an allegation of ulnar artery occlusion, which was an allegation against the surgeon that he had done some incorrect procedure during surgery, but we were able to show, but I was able to show in this case that there was sufficient collateral vascularity that indicated that the occlusion had likely been there for a long time. But here's an example of the angiogram showing the MR findings, and you can see here the radial artery coming down here. We have the ulnar artery over here, and you can see that there's a termination right over here, which is the ulnar artery occlusion. You can see the sequential filling of the vessels on the MR angiogram. Well, these can be presented in electronic or storyboard format. Here's just an example of what a storyboard format would look like. What does the radiologist bring to the table? Well, I think the following: an educated selection of images, not simply documentation, distillation of the relevant arguments in a visual format, clarification of the findings, highlighting the important imaging features, and then very importantly, simplification, because you want to give a jury, give people a simplified view of things that is accurate, but that they can take away with them and they can understand. Well, sometimes it's not only the images that have to be described, but sometimes it's the technology that has to be described. So here was a display that I made for a case showing image contrast and talking about the issue of contrast resolution, and contrast being the variation in appearance from the foreground to the background and how that affects how an image is perceived. So using just a very visual example here, we all know how animals blend into their environment. Well, that's an example of poor contrast resolution. Well, this issue of contrast is used in medical imaging all the time. We use these things called phantoms to actually try to calibrate machines to optimize the contrast. I won't go through all the details here, but these are just some other items showing differences in contrast. These circles up here are showing a variety of densities within them, which are more or less available depending on what the contrast is from the foreground to the background, showing some explanation of what contrast is. And here was the issue in this case was in a mammogram where we have, and this was an example, this wasn't the actual case, but this is to show how does contrast affect how a radiologist can view and perceive the images. So in this instance here, we have very good contrast. We can actually see this very small density here, which is more dense than the surrounding tissue, but in the same image depicted in a different way, this was actually using digital imaging over here versus film screen imaging over here in older technology, the lesion is practically invisible. So results that I've had with this are that I have provided demonstrative evidence in a number of cases, both med mal and personal injury. The presentation has almost uniformly been very instrumental, and the vast majority of cases were decided in favor of the side presenting the demonstrative evidence. Well, the demonstrative evidence educates the jury. It educates also the opposing side to facilitate realization of weaknesses in their case. And I think this is very important because, you are educating the jury, but you're also trying to make a case to the opposing side. And I have seen that in some cases, this may stimulate more rapid and favorable settlement when you have a compelling argument and something that is graphically presentable. And it also, importantly, too, from the point of view of the expert witness, it allows the expert to conclusively and comprehensively state his position without distraction from opposing counsel. So it essentially allows him to give his direct examination without any, in a very logical and well thought out format. Well, there are a variety of practical considerations. Which exhibits are you going to use? How are you going to use it? During examination of your own expert, the opposing experts in argument, and a variety of other issues here. Who's going to prepare the exhibit? How are you going to get it into evidence? And Morris will talk about some of that a little bit later on. Well, what does the radiology consultant do? Well, it depends to some extent which side you're on, but basically you are trying to present a cogent argument in support of the case. Now, here's an example of how you can do this. I mean, in this particular case, taking an X-ray and bringing it to illustration. This was a case where there was an allegation, and actually the attorney in this particular case was a board-certified neurosurgeon as well. So there was an allegation in this case that surgery was improperly performed, and I was provided only with this very poor quality intraoperative film of the patient who was undergoing surgery. Well, to try to clarify that and to figure out exactly what was going on, the issue here was that the patient became paraplegic after the surgery, and the allegation was that the clamp that we're seeing over here was misapplied. And actually, what you can see here, and I went back and illustrated overlays on the films themselves, and made digital copies of these, and outlined so that you could see exactly what we were dealing with here. So here is the clamp, and here is a hook. Okay, these are designed to separate tissues to give the surgeon an exposure. We have the vertebral bodies over here, and we have the spinal canal over here. So this is placed in the preoperative, in the initial view, and you can see that there's a different relationship between the plate here and the tip of the hook. And on the subsequent view, you can see that the relation the hook is much more anterior than it was before. Well, what does that mean in terms of what we were actually seeing? Well, if we go back and look at a schematic of what exactly the clamp looks like, this is more or less what it looks like. And we did several iterations, and I did these basically in concert with the neurosurgeon attorney to get to a point that he was satisfied with. But here would be the initial view that we were looking at, showing the initial iteration, showing the clamp and the hook there. And actually, we got to a point where it showed the plate, the blade over here, and you could see that the hook here is much more anterior. So this would correspond with what we were seeing on the subsequent X-rays. And here was the final view showing the proper placement of the hook and the blade at the initial point of surgery, and then at some point it had slipped. They had to reposition it, but this is what you would have seen had you been able to look at the actual patient at the time. So this graphically illustrates what we're dealing with before and after, and the injury to the spinal cord. Sometimes you need to look at things and say, okay, what are we actually looking at? Are we looking at things that are real or that are not real? Here are a couple of cases showing things that were called fractures, but they actually weren't fractures. This was normal wedging of a vertebral body of the thoracic spine, but it was called a compression fracture, and it really was not. Here was a congenital abnormality of the anterior arch of C1 that was incorrectly called a fracture. Sometimes you need to illustrate whether something can actually be seen or not. Here was a case where there was this mentally challenged man who presented to the emergency room with shortness of breath. His initial X-ray is depicted here. The emergency room correctly interpreted this as showing bilateral pneumonias, which you can see here and here. I was asked to look at this, and I, along with about 6 other radiologists who looked at this, failed to appreciate the actual finding here, which you can see very faintly up here, and is illustrated in this close-up view. And it turns out that this guy was eating mussels, and he actually aspirated one of the mussels, and this is the shadow of the mussel shell, and nobody picked up on that abnormality. So sometimes you want to display these types of things to the jury, and this can help you do that. Now, here's an example of an illustrative exhibit, an imaging sequence of subdural hematoma. This was an individual who was having headaches, who went to his primary care physician and had a sinus CT scan, and subsequently presented with severe headaches about a week later with a subdural hematoma. Well, what is a subdural hematoma? What I've tried to do here is show what that is so that people have an appreciation for that, showing that it's a collection of blood between the skull and the brain, showing a close-up view with the layers covering the brain so that people have more of a microscopic view of what that is, where exactly what the subdural space is, to try to illustrate that to the jury, showing the difference between a normal and the presence of a subdural, that is the blood collection between the brain and the bone, and some artist rendition as to what a subdural hematoma looks like here, with a corresponding CT scan over here showing the subdural hematoma, the mass effect, displacement of the ventricles, and all the other findings. This is a pathology example of the same thing. This was the patient. This was a baseline study from 2005. No subdural hematoma was present. Here we had the initial CT scan that was done October 2008, October 9th. It was done on a Thursday. And very faintly, it probably is even hard for you to see, even with the label here, but there is a collection over here. And because this was done as a sinus CT scan, you really couldn't see contrast between the brain and the subdural. So what I've done here is colorized it to show where the subdural is. And you can see actually very faintly here the cerebral ventricles, showing that there is some distortion of this one compared with this one because of the underlying mass effect. But what happened was the guy had this CT scan. It was done on a Thursday. The physician was notified about it on a Friday. He never called the patient. The patient stayed over the weekend and into the following week, finally presented with severe symptoms the following week, and ended up having a much larger subdural over here, which you can see more clearly here because this is a brain CT scan, so the contrast between the brain and the subdural collection is much greater here. And instead of whatever, I think it was 9 millimeters before, it's now 22 millimeters in thickness there, and you can see it colorized there with more mass effect. So here again showing the subsequent scan, basically showing the same thing. Here showing the degree of midline shift, which was about 12 millimeters here at this point. Here illustrating for comparison the fact that there was a change from the initial study from the week before to the subsequent one, showing that this thing had gone from 9 millimeters thick to 22 millimeters thick with the corresponding increase in midline shift. And again, just showing more of the same in a magnified view and showing his post-operative changes here. So the conclusion in this particular case was that the subdural hematoma was present on the initial study, and it significantly increased in size on the subsequent examinations. Here is an explanatory exhibit where there was a young child, a 10-year-old boy, who had a sports injury in September 2006, subsequently had a second injury in 2007. And what happened here was that the first injury was a very significant one. The second injury was very minor. The allegation here was that the injury and all the subsequent problems that this child had was due to the second accident only, which was really not the case. And I was able to show that in this case, showing that the abnormalities were present in the initial accident and not anything really of any consequence on the second accident. And I won't go through all the details here in the interest of time, but basically, again, to show the jury and to try to explain to them what are the different imaging modalities, what do they use, how they're used, what do they show, what are the medical terms that we need to understand in this particular case, acute, chronic, what is the epiphyseal plate, the growth plate, all these technical terms, more examples to show what the bone looks like, where the growth plates are, what we're dealing with in this case, what the normal anatomy is, in contradistinction to what the x-rays look like, what a normal x-ray of the knee is, and here we're showing the growth plate as this lucent line right here in the femur, and here we see the initial accident. Now, you don't need to be a radiologist to understand this. You can clearly see that there's a huge fracture here, complete disruption of the growth plate, subluxation of the femur, and a fracture fragment. And we then have subsequent views. This is all sequential views from the same patient, in a cast, out of a cast, and the image in question in this case was that when he went to see a physician subsequently, there was this area of sclerotic line here which showed that there was really fusion of the growth plate. And so there was some problem at this point in time. And there was also this area which is hard, I think, for you all to appreciate, but suffice it to say that there is a lucency here in this location, and I've enlarged that here to show it better. We've got this lucency over here, colorized in this instance, to show this osteochondral defect. So all these things existed in 2007 prior to the second accident in question. Here's an artist's depiction of what an osteochondral defect looks like. Here was the subsequent accident in 2007, showing that he has this sclerosis over here. He has this lucent lesion over here, which is the osteochondral defect with a sclerotic border. On an MRI, we can see the same things. We can see that instead of this line going all the way across here, like we have down here in the tibia, it's occluded and fused at this point, and we have this osteochondral defect without the typical edema and the findings that you would see if it was an acute injury. So basically what this all points to is that the lesion and the findings on the studies that were done subsequent to the second accident really had all been there prior to the second accident and were really due to the more significant first accident. And I went through here, and I won't bother with all this now, but showed all the conclusions, the causality in this case showing that it was the primary accident of 2006, not the subsequent accident of 2007 that was responsible for the abnormalities involving the growth plate. Just one final quick example here showing a patient with a lung cancer case. In this case, I was not an expert witness. I was asked by the attorney and by his own expert witness to produce this, and I did so. Here was the initial chest x-ray of this gentleman from 2002, which was essentially unremarkable. Here was a subsequent chest x-ray in question from 2006 showing only the upper lung zones. And I think it's hard for you to appreciate, but there is a little density over here on the left, and this turns out to be what the lung cancer actually was. Here what I've done is colorized it to highlight that and show that a little bit better, and then to correlate that with the subsequent studies a year and a half later showing that there was a large mass here in the left upper lobe, and colorizing it, showing what the exact measurements of this thing were, illustrating what the subsequent imaging studies, the CT scan showing this large mass, again here and here, and an MRI scan showing in the coronal plane, that's a frontal view, showing that we've got this large mass and there's actually some extension of that into the hilum and mediastinal structures. So it had spread at that time. So basically, in conclusion, I hope I've given you some illustration as to what demonstrative evidence can achieve, how it can be used, and how it can help make your case, whether it's the medical malpractice or in even personal injury cases as well. And I think that the radiologist, because of their specialized training, knowledge, and experience, is qualified to be both an expert witness and is also uniquely positioned to help provide the demonstrative evidence, which is a central part of many medical legal cases. And if any of you have any questions or comments or would like to contact me, that's my email address, and my website showing some more examples of this demonstrative evidence is available at the following location on the internet. So I thank you for your attention, and I appreciate your taking the time to listen. Thank you very much.
So I will I'll just wrap up briefly by going through some of the evidentiary considerations that are involved in presenting this kind of evidence. I'm going to take the screen back, and okay, so I think that works. So for starters, I'm sure everyone has some level of familiarity with actually admitting medical imaging. So I just want to make the point at the outset that in terms of the admissibility considerations that I'm discussing, this is with specific respect to admitting the demonstrative evidence, that is the annotations and the markups that go on top of the imaging and the diagramming that goes on top of that. There are really a couple of opportunities for it and a couple of different ways to approach it. One is if you're interested really in just getting a jury view, but you're not as concerned about admissibility in terms of bringing things into the jury room, of course you can treat this stuff as a chalk. It can also be used potentially as a basis for the expert's opinion, depending on what the evidence is. The other option, the more difficult option, but obviously the more effective one, is to actually admit some of these materials as evidence. And I'm going to talk about each of these very briefly. So in terms of a chalk, and this is just using Massachusetts law, remember the purpose is that it's illustrative. And so the standard is whether the chalk is sufficiently similar to make the observation of any value in aiding the jury. And the standard was articulated in Commonwealth versus Chipman, I'm sure in many other cases as well. I happen to like this particular quote. I think that makes the illuminates the standard for admitting a chalk, or excuse me, not admitting a chalk, but for presenting a chalk. Another option is to use the evidence as the basis for the expert's opinion. I say risky because, of course, if the evidence itself is inadmissible, then the expert's opinion based on that is also going to be inadmissible, at least in Massachusetts. So what can I tell you about that? In Massachusetts, we haven't adopted the federal rule, which would allow the expert to base their opinion in part on some inadmissible evidence, provided that's in fact reliable. So this is a specific consideration to taking the approach of admitting, of using this evidence as the basis for the expert's opinion. This is going to fall under a Daubert-Lanigan analysis. You're going to want to be very careful to be sure that the methodology is reliable, or alternatively, if you're going under the Frye standard, that it's generally accepted in the scientific community. Both will count in Massachusetts. And again, just to note that Massachusetts has not fully adopted the federal rule 703, which would allow the expert to base his or her opinion on otherwise inadmissible evidence, provided that it falls under the Daubert reliability standard. The other option here is to actually approach the evidence from the standpoint of admissibility. And this is the familiar standard if it's relevant and not unduly prejudicial. And it's important to keep in mind under this route that demonstrative evidence is not expert opinion evidence. In fact, it doesn't fall under Rule 703 at all, or the corresponding Massachusetts case law. However, it's important to keep in mind that expert opinion testimony can sometimes be based on demonstrative evidence, as I just discussed, and that in the alternative, expert opinion testimony can help to authenticate and establish the of demonstrative evidence. So there may be some overlap and some reasons to consider the expert witness testimony that you're presenting, and whether or not that is in fact reliable under the Daubert-Lanigan test. However, it may not be the end of the line for actually getting this stuff into the jury room. Relevance, obviously, a refresher. As everyone knows, relevant evidence is evidence that has a tendency to make the existence of any fact that is of consequence to the determination of the action more or less probable than it would be without the evidence. There are two pieces to that. The evidence has to have a probative value, and it has to speak to a material issue in the case. In specific to demonstrative evidence, there are two cases that I want to highlight, and there aren't many on this, but Kamal versus Place dealt with photographic demonstrative evidence and said that it was admissible so long as it was relevant to a contested issue in the case. And then another one, Ducharme versus Hyundai Motors, which upheld the admission of demonstrative evidence even though there was some dissimilarity between that evidence and the underlying matter, because there was enough similarity between the tests that were run in that case and the underlying matter that it was probative and it was of value to the jury. The last thing to consider is kind of the other bookend on this is undue prejudice, whether this is going to affect the jury in an impermissible way. And the standard was recently articulated under Kamal versus Bonds. And the main issue here is not going to be so much an issue of prejudice, but an issue of whether or not the jury has been misled. And so in that respect, you want to be very careful when working with demonstrative evidence to be sure that it is in fact that the similarities are sufficiently drawn and that the jury can make a reasonable interpretation based off of that demonstrative evidence. And of course, keep in mind that that is at the discretion of the trial judge. So with that brief run through, I'd be happy to open it up to any questions from either part of the presentation. In case anything is accumulating, you can put that in the chat feature of the GoToWebinar panel that you see on your screen. And otherwise, we will wrap up, and I'll just say that I appreciate everyone for joining us and for learning about this important topic, and I hope this was of use to everyone, and thank you very much.